Okay, welcome everyone. If you're an orthopedic resident, prepping for those big postgraduate exams, the FRCS, maybe a fellowship assessment, well, pressure, it's intense.
Absolutely. Balancing clinic, the OR, and just this mountain of information. It's a lot.
Yeah, exactly. And that's really where we're doing this deep dive. We want to cut through some of that noise,
Hmm.
distill the really critical stuff.
Sort of give you a shortcut to feeling confident and well-informed without having to reread entire textbooks the night before.
Precisely. We're aiming to pull out those key insights that really stick, make it actionable.
Turn data into understanding you can actually use.
So today, we're tackling a topic that you'll definitely see, both in your daily trauma calls and, yeah, on exam day. Distal femur fractures.
Mm-hmm. A real cornerstone.
And just so you know, everything we're digging into today is based on the fantastic Ortho Made Simple notes. You can find them over on mokyingren.sg.
Yeah, they're excellent resources.
They were put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, finished his FRCS back in 2022. So really current practical stuff.
And these fractures, distal femurs, they're not just about knowing the classification. It's about the clinical reasoning behind the decisions you make, often high-energy, complex injuries.
Right, so let's get into it. Let's unpack the basics first. When you're looking at a distal femur fracture, what's the first thing, like mechanically, that should jump out? What are those deforming forces doing?
Well, the big one, the one you're always fighting against, is the gastrocnemius. That muscle pulls relentlessly. It almost always causes that distal fragment to flex, to pull backwards. So, when you're reducing it, you often have to think about relaxing that gastroc.
How do you do that practically?
Flexing the knee is key, putting a bump under there. If you don't account for that pull, getting alignment is just, well, much harder than it needs to be.
That's a great clinical point. And speaking of things you need to actively look for, what about the Hoffa's fragment, that coronal piece?
Yes, the Hoffa's, a classic pitfall. It's a coronal plane fracture of one of the femoral condyles.
And it's pretty common.
Surprisingly common. Found in about 38% of all distal femur fractures. And here's a key detail. 85% of them are on the lateral condyle.
Lateral.
So you need to be really looking for it laterally. Plus, it's almost 3 times more frequent in open fractures. Tells you something about the energy involved.
A coronal fracture. I imagine that's tough to see on plain x-rays sometimes.
That's exactly the problem. And this is really critical. Up to 30%, nearly a third of these Hoffa's fragments can be totally missed if you only rely on plain films.
Wow, 30%?
Yeah. The work by Nork and his colleagues, the JBJS paper, really highlighted this. It's just inherently hard to see that coronal split on AP and lateral views.
So the take-home is?
You need a CT scan. It's not optional if you suspect an intra-articular fracture or even a complex extra-articular one. You just have to get the CT to fully define the pattern and rule out that Hoffa's. Missing it is, well, it's bad.
Got it. CT is essential. Okay, so once we have characterized it, we need to classify it. What's the go-to system?
We rely on the AO trauma classification. It's logical. You've got your A types, extra-articular, outside the joint.
Okay.
Your B types, partial articular, where some part of the joint surface is fractured, but there's still some continuity between the shaft and the joint.
Right.
And then the C types, complete articular. The joint surface is completely separated from the shaft, basically increasing complexity from A to C.
Makes sense. Now, let's jump into the OR. We've got the fracture classified. Alignment is everything. How do we check rotation intraoperatively? What are the tricks?
Rotation's tricky but crucial. Several ways to gauge it. You can look at the cortical width, making sure it looks symmetrical compared to more proximal. The lesser trochanter shape sign is another good one. How much the lesser troch you see on AP fluoro tells you about rotation. But probably the most practical tip, save a fluoro image of the good leg, the contralateral side, making sure the patella is pointing straight up, dead center. Then use that image as your template for the injured side.
Like a direct comparison.
Exactly. It's a really effective real-time check. Just make sure that contralateral image is perfectly positioned. Otherwise, you're comparing apples and oranges.
Good point. Consistency there is key. So that's rotation. What about coronal alignment? Making sure it's not varus or valgus.
For coronal plane, the standard is the cable method.
Okay, explain that.
You use the diathermy cord or a long radiopaque cable. Stretch it from the center of the femoral head down towards the ankle. It should pass right through the center of the tibial plateau, the center of the knee joint.
Visualizing the mechanical axis.
Precisely. It's a quick visual confirmation that you've restored that straight alignment in the coronal plane. Simple, but it works.
And getting the bone to that aligned position reduction techniques. What are the essential tools and setup points?
First, positioning. Always have a bump under the knee. Lets it flex. Helps relax that gastroc pull we talked about.
Right.
Then for tools, circlage wires can be useful for certain patterns, carefully placed. A femoral distractor is invaluable. Pins in the femoral shaft. Pins in the proximal tibia allows controlled distraction and ligamentotaxis to help pull things out to length and alignment.
Like an external fixator, almost, but temporary interrupt.
Kinda, yeah. And Schoen's pins placed directly into fragments give you joysticks, handles to manipulate them precisely.
Okay, great overview of the basics. Now, let's dive into a specific scenario. Say you have an AO33A fracture, extra-articular. What's the main decision point for treatment?
For a 33A, the big debate is usually retrograde nail versus plate. Both are good options, but with different profiles.
Okay, let's take the nail first. Pros and cons.
Retrograde nail. The big pros are usually immediate weight bearing as possible, it's load sharing, which is biomechanically favorable, and it's generally less invasive surgery, smaller incision.
That's good. The downside.
The main disadvantage is you are violating the knee joint. You have to go through the intercondylar notch, potentially damaging cartilage. That's the trade-off.
Okay. Now, what about plating that same 33A fracture?
Plating's main advantage, especially in, say, osteoporotic bone, is potentially better fixation, better purchase in the distal fragment. You can get multiple screws locked into that distal block.
And the approach for plating an A-type.
Typically, a lateral or maybe an anterolateral approach is standard for these extra-articular ones. If you had perhaps really bad medial comminution or the bone quality was so poor that one plate didn't feel stable enough, you might consider adding a medial plate via a subvastus approach, dual plating. But usually a single lateral locking plate does the job for an A-type.
So let's synthesize that. For an extra-articular distal femur fracture, what's the overall surgical game plan? The philosophy.
The goal is stable fixation, absolutely, but with minimal soft tissue stripping. You want to preserve that periosteal blood supply to encourage healing and, crucially, allow early range of motion.
Because stiffness is a major enemy here.
Huge enemy.
Right.
So steps are, position well, bump under knee, then get your reduction. Check it meticulously, rotation, using those signs we mentioned. Coronal alignment with the cable. Make sure length is restored. Temporarily fix it, maybe with K-wires. Then apply your definitive fixation, usually that lateral plate, post-up, generally non-weight bearing for about 6 weeks to let that initial healing consolidate.
Okay. And if you chose the retrograde nail instead, any specific technical pearls for that procedure?
Definitely. For the retrograde nail, incision is usually transpatellar or maybe parapatellar. The starting point for your guide wire is absolutely critical.
There should be.
On the AP view, dead center, in line with the canal. If you're eccentric, you'll ream eccentrically and risk blowing out a cortex.
Right.
On the lateral view, you want to be right at the distal tip of Blumensatz's line. That's the roof of the notch on the X-ray. That's your entry point into the canal.
And the length of the nail?
Good question. You should aim for the nail to extend proximally across the level of the lesser trochanter.
Why so high?
To avoid creating a stress riser. If the nail stops short in the diaphysis, you create a stress concentration point right at the tip. And the femur can fracture again just above the nail. Going past the lesser troch distributes the load better.
That makes perfect sense. Okay, avoiding stress risers is key. Let's shift now to the really complex ones. The AO33C, the complete articular, often comminuted fractures. What are the go-to surgical approaches here?
Yeah, these C-types can be challenging. Your primary workhorse approach is usually a lateral approach to the femur, but you need to extend it distally with an anterolateral arthrotomy.
So you can see the joint surface directly.
Exactly. You need wide exposure to piece that joint surface back together anatomically. If there's significant medial comminution needing its own fixation, you'd add a separate medial subvastus approach for a medial plate.
Any other approaches considered?
Well, the lateral parapatellar swashbuckler approach gives fantastic exposure. You can really open the whole thing up. But the big drawback is the potential trouble it causes for a future total knee replacement. That incision can really compromise the standard TKR approaches later on. So many surgeons are a bit hesitant to use it unless absolutely necessary.
Something to keep in mind for the long term. Now, what about those really tough situations, maybe an elderly patient, multiple comorbidities, bone like chalk, or just a severely shattered C-type fracture where fixation seems almost impossible? Any alternatives?
Yes, absolutely. In those challenging cases where standard ORIF, open reduction internal fixation, seems like it might fail or the patient wouldn't tolerate the rehab, you have to consider other options.
Gotcha.
A primary total knee replacement, but with a stemmed component, might be a good choice. It addresses the fracture and the arthritis in one go, gets them potentially weight-bearing faster.
Okay.
And if the bone stock is just truly awful, really deficient distally, then a distal femoral replacement, basically replacing the whole end of the femur with a large prosthesis, becomes a salvage option. It's a bigger operation, but sometimes it's the most predictable way to get a stable, functional limb.
All right, sometimes salvage is the best option. Okay, let's talk about another complex scenario. Converting a previously fixed distal femur fracture, maybe years later, to a total knee replacement.
Mm.
This isn't your straightforward primary knee, is it?
Not at all. You should absolutely think of this as a complex primary TKR. It needs way more planning.
What are the key pre-op considerations?
Templating is crucial. You need to know where the old hardware is, especially screw holes. You must plan for a stem that will bypass the most distal screw hole, otherwise, guess what?
Stress riser again.
Exactly. If your longest available stem on the template doesn't bypass those holes, you might even need to consider a staged procedure. Remove hardware first, let it heal, then do the TKR.
Wow, okay. What else pre-op?
Always, always have stemmed implants and augments, metal wedges, or blocks available in the OR. You just don't know what bone loss you'll find until you're in there.
Be prepared for anything.
Pretty much. And you have to carefully assess the old skin incision or incisions. Deciding which one to use, or if you need a new one, is critical for wound healing.
So, intraoperatively, what are the main steps for this conversion?
Exposure is key. You might need a more extensile approach than usual, like a quad snip or even a tibial tubercle osteotomy in really stiff knees, though you try to avoid the latter.
A good visualization.
Then, careful removal of all the old hardware. That can be tricky in itself if screws are stripped or broken. Then, assess the bone stock very carefully. Replace any deficiencies with cement, graft, or those augments we mentioned.
Yeah. Right.
And finally, implant the TKR, making absolutely sure that stem bypasses any old screw holes by at least 2 cortical diameters. That's the rule of thumb.
2 cortical diameters. Got it. And rehab after these complex conversions.
Usually you can still aim for full weight bearing as tolerated. The stem provides good initial stability. Mobilization is key.
Okay, let's circle back to those skin incisions, because that seems really important, especially if there are multiple old scars. What are the rules for managing that?
This is critical for avoiding wound breakdown or skin necrosis, which is a disaster. The #1 principle. Try to maintain a skin bridge of at least 7 centimeters between your planned incision and any old longitudinal scars.
7 centimeters. Okay, what if you can't?
If it's impossible, you generally have to incorporate the old scar. If connecting 2 scars, try to do it at an angle, maybe around 60 degrees, not sharply.
And if you have a choice between, say, an old medial scar and an old lateral scar?
The general rule is use the most lateral incision.
Why lateral?
Because the main blood supply to the skin over the anterior knee comes predominantly from the medial side branches off the femoral and popliteal arteries, forming an anastomosis. Going lateral is generally safer for skin viability.
That's a key anatomical point. What about old transverse scars?
Transverse scars, like from an old knee scope perhaps, can usually be ignored. You can typically cross them without the same level of vascular concern as longitudinal scars.
Okay, now, what if you face a real mess? Multiple old scars, maybe crossing, skin looks compromised. Is there anything else you can do? You mentioned insol earlier.
Right. For those truly difficult soft tissue envelopes, there's insol's delayed incision technique. It's quite clever.
How does it work?
You basically do it in 2 stages. Stage 1, make your planned skin incision, carefully eliminate just the skin flaps needed for the arthrotomy you would do, and then you just close the skin.
Without doing the knee replacement.
Exactly. You close it up, regardless of how it looks initially. Then you wait typically 4 to 6 weeks. If the skin survives, shows no signs of necrosis.
Then it's proven itself viable.
Precisely. Then you go back through that same incision and perform the TKR. It serves 2 purposes. It tests the skin flap's blood supply, and the initial surgery actually seems to encourage some increased collateral circulation through the healing process. It's a way to optimize a bad situation.
Fascinating technique for complex cases.
Yeah.
Well, we've certainly covered a lot of ground today on distal femur fractures.
We really have. From the basic mechanics, that gastroc pull, the importance of spotting Hoffa's fragments.
Right. Through the AO classification, the nuances of nailing versus plating for extra-articular types.
to the approaches for those complex intra-articular C-types, and even thinking about primary arthroplasty or distal femoral replacement in some cases.
And finally, tackling those tricky TKR conversions and the critical aspects of managing old incisions. Hopefully this gives you a much stronger handle on these fractures.
Yeah, having this detailed understanding is genuinely vital, not just for passing exams, but for making good, confident decisions for your patients every day.
And remember, this deep dive was grounded in those excellent Ortho-Made Simple notes you can find on mokyingren.sg, a great resource to keep revisiting.
Definitely worth checking out. It really highlights how dynamic these challenges are. It's never just about following a recipe. It's about critical thinking, assessing the patient, the fracture, the bone quality.
Absolutely. Every detail matters for the outcome. So, as you continue studying and working in the OR, keep thinking critically, keep questioning. How does each step, each decision, impact the patient standing in front of you?
That's the core of it. Keep learning, keep refining.
We hope this deep dive helped you on that journey. Thanks for joining us.